Some more injury epidemiology estimates are currently taking place. As I mentioned, there was a community-based survey, and then there will also be some long-term follow-up care that's occurring right now through our Center for Global Surgical Studies at UCSF. And then very quickly, because I want to jump to some major points, injury surveillance in Uganda was some of the work that we did with our partners there. And there was a 220% increase in motor vehicles. Why does that matter in our context? Because the engineering wasn't developed to be able to take on that kind of capacity. And if any of you have been to Kampala, you know about the jam, and it's really quite difficult to be a pedestrian in that kind of a situation, trying to get across the street safely. And we found that that the odds of dying from injury in Kampala, Uganda, relative to San Francisco was 5 times, and then the odds of having a head and neck injury were 3.5 times, 3.6 times. Again, the reason for that we thought was very likely due to the fact that there was very little helmet use. So injury prevention, the opportunity for the population to understand just how life-saving it is very important. And we did a pre-hospital intervention by training lay first responders, police officers, and taxi drivers, and this has been done also in Ghana, to be able to provide care, basic first aid, and get people to the hospital themselves. And I'll skip over a couple of these slides, but just to mention that that it's very common in Kampala for police officers to transport people to the emergency department. So we weren't building in any infrastructure, but this is just outside of the old casualty ward at Malago Hospital. All we did was just train in basic first aid. So the care that the patient received out in the field was much better as a result of that training. And they passed a particular course and demonstrated that they utilized the information and that they retained the information. So in other words, we recorded the encounters, and they really did a lot in terms of hemorrhage control, recovery position, glove, and we were able to provide gloves, gauze, bandage for them. So it was an exciting opportunity to affect change. So you can see how injury and the treatment of injury goes all the way from prevention to wearing helmets, to engineering roads for safety, to pre-hospital care, training, even if it's not formal ambulance care, training people in first aid, to being able to have an infrastructure in a hospital, taking advantage of the resources that already exist, such as the resuscitation bays that you have built, to be able to provide improved care for the trauma patient. And so one last point about understanding how to get at what the barriers and what the facilitators are in essential surgical care delivery. We worked in Soroti, Uganda, with our partners there, and we still do, to understand a little bit better about what these barriers and facilitators may be. We wanted to assess the surgical capacity. This regional referral hospital takes in 7 districts, so it was very important. It's a very important spoke in the wheel of care in Uganda. And we wanted to identify some of the barriers of quality care and observe and quantify the sequence and timeliness of essential surgical care. So we looked at surgical capacity assessment and identified the barriers and facilitators and determined the sequence. And this was just something that we looked at in terms of the number of patients in the surgical ward, and the female surgical ward and the male surgical ward. And this is the number of patients relative to the number of, or relative to the capacity, in other words, the beds. So a big issue we found was in the male surgical ward. These patients oftentimes were in underneath the beds of patients who were in traction. We actually have a study going on right now as to how much we can save in terms of people's morbidity and in cost savings if we are able to actually perform surgery on people with these broken bones instead of having them in the hospital in traction for 6 weeks. And that's an ongoing study that we have going on right now at Soroti, Uganda. And so with that, I want to skip over a little bit of this so that we have some time for questions and conversation. So I want to summarize a little bit about what this all means, and these are just for future directions for Kampala. So as I mentioned, I think that surgical care, and in particular injury, spans all the way from prevention to pre-hospital care to in-hospital care to being able to care for that patient with a spinal cord injury that we saw towards the beginning of this talk. That takes a comprehensive approach. But the good news is that through our partnerships with your colleagues in Cameroon and our colleagues in Uganda, we are recognizing that there's a cost effectiveness to treating patients either through prevention or treating patients with some areas of surgery that are actually quite low cost, such as general surgical procedures. As you saw, general surgical procedures are actually more cost effective than antiretroviral therapy. I hope I'm not offending anybody. But it's worthwhile for those of you who are treating patients with HIV, TB, malaria, many of the infectious diseases, to understand that we are one and the same, that this is the same population that's vulnerable to injury as well. And so we need to stand really hand in hand in terms of advocacy to have a more comprehensive approach and have surgery as part of that paradigm. So I did want to leave a few minutes for questions. I know that we covered a whole lot, but the last thing that I would mention, besides your opportunities with all of your white coats on to be great advocates for the ministry, would be also to spend some time, even though you're in internal medicine, really letting your patients know how important it is if they do ride a motorcycle or a bicycle to try to invest in a helmet, or again, advocate for opportunities for helmet distribution. It really saves lives, and as you can see, it saves disability as well. So, so that's the take-home message for the patient, for your communities, but for us as physicians and other healthcare providers, we really need to build surgery into the infrastructure of our daily routines. Thank you for your attention.